Hello and welcome to this screencast. This is a very short screencast related to a paper which we published a couple of years ago in the British Journal of Sports Medicine at the beginning of 2015, and it relates to a project which I did in collaboration with Dr. Dylan Morrissey at Queen Mary University London and the research team there. The paper is titled The Best Practice Guide to Conservative Management of Patellofemoral Pain. And this sets up a workshop that we're doing in Melbourne on July the 23rd and outlines a number of different interventions for a clinician to consider when treating individuals with patellofemoral pain. It's also related to an initiative of translating research evidence and knowledge, or TREC, and trying to drive some of this knowledge out into the rest of the world and get people to start to use and embrace the evidence that we currently have. So hopefully you find this brief screencast useful, and if you do, please feel free to forward on to your colleagues. So we'll move into the drive of this paper, the Best Practice Guide, and I think we're all very aware as clinicians that RCTs or randomised controlled trials and systematic reviews have a lot of limitations in terms of guiding our clinical practice. When we look at the evidence-based pyramid, we see systematic reviews sit at the top. We also see meta-analysis below that as part of systematic reviews, and just below that, randomised controlled clinical trials. Now, one of the things that we have, and I'm a clinician myself, and we get a lot of frustration that we get to the end of a systematic review or a clinical trial and it will conclude that maybe we can't actually use anything that might be studied out there because it's a small population in terms of the breadth of the population, or there's often conclusions that say we need more research. However, we're lucky in patellofemoral pain and there's actually quite a decent amount of research out there, and we do have some good conclusions that we can draw from the literature related to systematic review findings. But there are still limitations. At the end of the day, clinical practice is not a randomised controlled trial, and if we based our treatments purely on randomised controlled trial findings, then we wouldn't be doing a lot to help our patients. So for me, clinical practice is an art guided by science, and the science still remains very important. But at the end of the day, we need to treat the individual patient in front of us. And that means considering the evidence, but also considering our own clinical experience, considering the patient's preferences and values. But also we can draw on a lot of expert opinion as well. There's a lot of individuals out there who have been both researching patellofemoral pain and treating patellofemoral pain for a number of years. And some of their knowledge just can't be portrayed through a clinical trial. So that's where I sort of come at this from in terms of thinking about, well, how can we create a clinical guide for managing patellofemoral pain? So we published this paper at the beginning of 2015 and it's still available open access via BJSM as one of the editor's choice articles. Now we took a two-stage or three-stage approach. The first stage was to quantitatively evaluate the literature. So what we did is we summarised findings from high-quality systematic reviews. So these systematic reviews were published within the previous 5 years and related to conservative interventions, and in total we identified 6, which covered your common interventions including exercise, foot orthoses, taping, bracing. We then interviewed 17 international experts, and these international experts were both researching patellofemoral pain actively and contributing to international meetings, but they were also treating patients, so they had a clinical insight into how the evidence could be applied. What we asked them was a range of questions through semi-structured interviews related to their clinical reasoning in patellofemoral pain and how they applied the evidence, what treatments they may have used that wasn't evidence-based, and maybe where we need to head in terms of future research. Then what we did is we synthesised these two streams of research together, so the quantitative and the qualitative, so taking a mixed methods approach to combine and then to create a treatment guide that may help us to treat our patients with patellofemoral pain. I won't go through the paper in detail, but you feel free to have a read of it online via the British Journal of Sports Medicine website. But in simple terms, we split our intervention options into 3 broad categories. First category being education, which is seen probably as the most important intervention, and Michael gave a fantastic presentation on an adjunctive screencast. Active rehabilitation, and I'll talk more about that in another screencast and really look forward to unpacking the research around that in the upcoming workshop. And then passive interventions, which is primarily around trying to optimise or trying to reduce pain in individuals with patellofemoral pain. So if we look at some of the specifics, what we can see is we have level 1 evidence for patellar taping, we also have level 1 evidence for patellofemoral bracing, and we also have level 1 evidence for foot orthoses. What you'll notice throughout this guide is there is some normal text and there is some italics text. Now the normal text relates to supporting level 1 evidence, whilst the italics text is related to more lower level evidence and or the combination of expert opinion. So we can see very clearly taping, bracing and foot orthosis seem to be supported by level 1 evidence. But there's a number of other things that we should consider. Foot orthoses may not be effective for every individual with patellofemoral pain, and we possibly should individualise both who we give them to and also how we might prescribe and customise these orthoses. And I'm looking forward to Bill's contribution on the day as part of the workshop and a couple of the screencasts for those participants who will be coming along, which will also be made available to registrants. The second thing is we need to not throw away massage and acupuncture and dry needling. They're not likely to be a priority, but they may still be beneficial in terms of pain reduction and or improving flexibility if that may be an issue for each individual. We need to think about patellofemoral joint mobilisations, but probably not in the presence of hypermobility. And in fact, in a recent consensus statement that the International Patellofemoral Community put together, patellofemoral joint mobilisations were not recommended, and this probably fits with the fact that most of our patients with patellofemoral pain are generally hypermobile, but we do get the occasional patient who might be hypomobile, and that may be something you need to consider. We also need to think about mobilisation of the ankle and the first ray. If we have limitations to our sagittal plane function of the foot and ankle, then that's going to impact on the frontal and transverse plane mechanics. So thinking restricted ankle dorsiflexion, we may end up with greater foot pronation, leading to greater tibial internal rotation and femoral internal rotation, and possibly leading to more of a valgus collapse. So considering these as potential limitations and addressing them where necessary can be quite important. And Bill will go over some of that as part of the workshop. When we look at active interventions, there's a number of principles that we need to consider. So preference to closed kinetic chain to replicate function. And in the adjunctive screencast related to common deficits, you'll remember I talked about the fact that probably the hip is the one driving patellofemoral joint maltracking when we're in a closed chain position. So ensuring that we do exercise rehabilitation in a closed chain position is very important. However, at the beginning and the early stages of rehabilitation, we may need to target open kinetic chain exercises, particularly if there's isolated strength deficits, or if we need to target specific movement patterns. And that's something that can be very important to incorporate. So usually the combination of both is going to lead to better outcomes. Supervision in the early stages is obviously very important, but at the same time, we also need to ensure that we progress patients to independence. From an economic standpoint, patients can't afford necessarily to be attending physiotherapy clinics every week to be supervised of their exercises, and particularly within a public health system, this is not always practical as well. From a home exercise perspective, one thing we don't want to do is overburden our patients with too many exercises, so sticking to 3 or 4 exercises will help to aid compliance. At the same time, though, we do know that there seems to be a dose response to exercise in patellofemoral pain. We have research that indicates that. So one of the important points may be that we do need to consider possibly longer exercise sessions, but maybe just 2 or 3 times a week, and possibly as part of a gym program. And I look forward to talking more about that as part of the workshop and going through how we might implement that practically. We can consider biofeedback, including mirrors and videos to improve exercise quality. Patients all pretty much have a smartphone these days, so videoing their exercise regime so they can take it home and follow it accurately can be quite important. And then when we look at specifics, we need to incorporate quadriceps and gluteal strengthening, so thinking about hip musculature. And this importantly has level 1 evidence, so it has great supporting evidence that these are effective in reducing pain and also improving function. And I'll talk more about that in a screencast to follow. But we also need to think about targeting distal and core musculature, particularly where deficits in these muscles exist. Stretching can be helpful, particularly where tight musculature such as calves and hamstrings might impact on normal sagittal plane mechanics of the knee or increase tension around the knee. And we have emerging evidence that movement pattern retraining, and in particular running retraining, which focuses on reducing hip adduction, can be effective in managing patellofemoral pain. And this may be beneficial for other tasks, and we'll go through some of this practically as part of the course in terms of when and how to incorporate it, but importantly, what are the barriers and what are the facilitators to making it happen, and what are some of the more structural influence that might indicate that we shouldn't be trying to change something that can't be changed. And I think that's incredibly important. And then the most important intervention that we need to consider relates to patient education. And as I mentioned before, Michael has given a really great screencast related to this, and I really encourage you to watch this. But the 4 key points to consider is making sure patients understand the contributing factors to their condition and what the treatment options are. If they don't understand these things, then it's very unlikely that compliance is going to be achieved. Advising about appropriate activity modification. Most people with patellofemoral pain, the biggest issue can be their activity levels and fluctuations of this, trying to do too much too soon, whether that causes the onset of pain or whether that's trying to get back to activity after development of pain. Advising around this is incredibly important. Managing expectations around rehabilitation is also important. If patients don't understand the time required to address muscle function and muscle strength deficits they may have developed as a result of the vicious cycle, which I've talked about in the common deficits screencast, then they're probably not likely to comply and probably not likely to get better in the longer term. So really managing those expectations about what's required for their rehabilitation. And that fits very well with the 4th point, which is emphasising and encouraging the importance of active participation in their rehabilitation. At the end of the day, it's their condition that they need to manage, and we're there as the guider in terms of trying to help them to manage the condition. Michael will have talked about the Managing My Patellofemoral Pain education leaflet that we created, and we chose that title for a very good reason, Managing My Patellofemoral Pain. So I think that's an incredible important point. So look forward to seeing some of you at the workshop, and also please, if you haven't already, watch some of the other screencasts, which will hopefully give you a bit more insight into how to improve our management of this very common and very problematic condition. And I'd like to thank you for your time and having listened. Please feel free to forward on to anyone else who you think may be interested. Thanks very much.